Hello, my name's Aaysha Cader, and I'm delighted to be joined by Professor Divaka Perera, who is Professor of Cardiology at King's College London and Consultant Cardiologist at Guy's and St Thomas's Hospital. Welcome, Divaka, and thank you for joining us.
Aisha, nice to see you, and thank you for taking the time to talk about the paper.
Absolutely. So today we'll be discussing your paper, which is going to be published in the upcoming issue of JACC Interventions, and it's titled Randomized Comparison of Fractional Flow Reserve, FFR, and Instantaneous Wave-Free Ratio in Serial Disease. Could you tell us a bit about the background to this paper and the concepts of physiological assessment that you looked at in this paper?
Sure. So I guess it's worth starting with the background to FFR and IFR, both of which are physiological measurements that tell us about the significance of a lesion in a coronary artery. Now, these studies were all carried out and validated in patients who had single lesions in a single coronary artery. But we know that atherosclerosis is actually a more systemic process, and that even within one artery, there are often areas that are diseased, either a focal lesion and a diffuse segment, or two focal lesions, etc. In fact, if you think about it, it's more common for there to be disease beyond the one that draws your eye. So what we wanted to find out was whether in the presence of, when there are two lesions, whether you can evaluate the functional significance of one of them as though the other lesion didn't exist at all. And common practice is to do just that. So one evolution that's happened in physiology is that in addition to measuring the impact of the disease on the capability of the vessel to cause ischemia as a whole, that's just doing an FFR or IFR distally, we do a pullback, and the pullback tells us where the step up in pressure occurs. And what we think is that if you see a certain step up or gradient in pressure across a lesion, then removing that lesion by putting a stent in means that you will simply improve the FFR by that amount. So, for instance, if you have a pressure pullback and you have an FFR of 0.70, and you pull back, and across one lesion, it goes from 0.70 to 0.9, and then across the other lesion, it goes from 0.9 to 1. We think that removing the first more significant lesion will mean that you have an FFR of 0.9. Now, we wanted to test this and see whether that was true, because from basic principles, it shouldn't work like that. The presence of one lesion should affect the other, but it hadn't been systematically tested. The other background to this is that there's a belief that if they do interact, it's only during hyperemia. So only FFR is affected, that non-hyperemic measures like IFR are not affected. So the design of the study was we took patients who had angiographically two segments of the artery that were diseased, either two focal lesions or a focal and a diffuse segment, where you intended to treat at least one of the focal lesions. We then randomized the patients who consented to either be guided by IFR or by FFR. But the nice thing about the study was whatever the randomization was, the other measurement was also done. So interventional cardiologists in the study did both measurements, but they were only allowed to use one of them based on the randomization. They used IFR or FFR to guide the treatment. And the aim was you do a pullback, work out what you think you're going to get, the sort of expected IFR or FFR, treat that lesion, the target lesion, and then what do you get? Is there an interaction or not? And I suppose the headline finding is that we don't get it right. With both FFR and IFR, we hugely overestimate the impact that we think PCI is going to have. In other words, the actual physiological result is always worse than the one that you expect. And the reason is that the two lesions interact. So when you remove one lesion, the other lesion physiologically seems to have got worse. It hasn't got worse, of course. It's just that in the presence of both lesions, the true significance of one was masked. So the first finding was that we get it wrong. How often? in 34% of cases, you will leave the patient with a vessel that's still capable of causing ischemia. 1/3 of cases. That's one big result. The second result is, are FFR and IFR the same? Pretty much. Both with FFR and IFR, the error rate was about 34%. And this is a major finding for us, well, for the community as at large.
Right, that's actually very, very interesting because this is exactly the kind of patient subset that we very often encounter in the cath lab. So what do you see as the next step? This was, of course, a randomized comparison of hyperemic versus non-hyperemic index in serial lesions. But in terms of the next step, in terms of research in this field, what do you see as it being?
So yeah, it's interesting. So there is that 34% error, and we have to do better than that. And really, the principle is to try to predict the impact of your PCI before you do the PCI, and you may not even do the PCI at all if your prediction is that your result isn't going to be great. So actually, I meant to say that one of the other things that we assessed was the impact of doing even a pullback on outcomes, and that was perhaps the highest level finding. Just availability of the pullback, as opposed to doing just a distal FFR or IFR, changed the management strategy from PCI to either CABG or medical therapy in 1 in 20 patients or so. And then when you assessed whether the lesion that was chosen as a target lesion also changed, that was also changed by doing the pullback. So even doing a visual pullback is a good thing and a step forward. But leaving residual disease in 34% of cases is not good enough. We looked to see whether we can incorporate the physiology and make a correction. And we used a technique called virtue stat. It does reduce the error to about 8% from 34. That's a big advance, but it still means that you get it wrong in an unacceptable amount of cases. So practically, what does this mean to the interventional cardiologist who will be faced with this kind of disease very commonly? Number one, be aware that by just looking at the translesional gradient in pressure on a pullback, whether you're using IFR or FFR, you will overestimate how impactful your PCI is going to be. So you need to make that adjustment even qualitatively in your head. You can use virtue stent if you have that in your on your console, but you have to make an adjustment either numerically or qualitatively. Secondly, knowing that even with the best available methods, you're leaving the patient with the residual disease a lot of the time. Physiology after your target lesion should be mandatory. And you really need to check whether there's residual disease, because if you find that, at least you have an opportunity in the cath lab itself to treat this patient. Yeah, don't be fooled by non-hyperemic, the notion that non-hyperemic measures are not prone to disease. It's simple physiology. Whatever method you use, there's still that tendency. So I think it's a big change. Do the pullback at the start, predict your result, do your PCI, do the FFR and pull back again, and then optimize. Don't let the patient leave your lab until you've achieved the result that you wanted to at the start of the case.
Thank you very much. I think that the underlying message here is the importance of doing that post-PCI physiology as well, and not to be lazy about it. I suppose.
I think so, Aaysha, but one of the important things from this study and others is that, let's say you have a left main lesion and an LAD lesion, and you do your pullbacks, and on the erroneous assumption, you think the left main is not significant. You treat the LAD, and you diligently, following the advice that I've just given, do a post-PCI pullback, and then you find the left main lesion is significant. Now, you might be in a situation that you didn't want to be in. You might have treated this only if it was the LAD and not if it were a left main. Had you known it was a left main, the patient might have gone to surgery. So for the field, the optimum situation is for us to be able to predict upfront what's going to happen. We don't have a solution yet, and until a solution becomes available, then doing a post-PCI physiology is the next best thing.
It's a really neat example of a practical situation most of us might actually find in. Thank you very much, Divaka, for this paper and for enhancing our understanding in this particular subset of patients that we often encounter in the cath lab. And for those of you watching, make sure you read the full text in the upcoming issue of JACC Interventions out on the 14th of July. Thanks very much, Divaka.
Thanks, Aaysha.